Okay. All right. Hi, everybody. Good morning. Welcome to our Health to Hold community resource webinar series. My name is Jenna Sistad, and I'm with the Ocean Monmouth Health Alliance, here joined by our bilingual community health worker, Leslie Montes Cruz. And we are excited to welcome you all here to our series where we recognize and highlight our community coalition partners on a monthly basis, while at the same time recognizing and raising awareness about the Health Awareness Month. This month happens to be Breast Cancer Awareness Month. So today we have the RWJ Barnabas team, more specifically Dr. Michael Simon, here to present with us. We are very excited to have Dr. Simon. And so I would like to just read his bio before we toss this over to him. We will be doing Q&A at the end. So if you have questions, you can feel free to put them into the chat box or wait until the end and we can take you off mute to have a further discussion. I'll also be providing some updates at the end of the presentation. So thank you for your time and your patience today. So a little bit about our presenter. Dr. Michael Simon is a dedicated breast radiologist with extensive training and expertise in his field. He earned a medical degree from the Sackler School of Medicine at Tel Aviv University and completed his internship at Maimonides Medical Center. Following this, he pursued a residency in diagnostic radiology equipment, Barnabas Medical Center in Livingston, where he distinguished himself as chief resident. Dr. Simon further specialized in breast imaging through a fellowship at Mount Sinai Hospital in New York City. He now joins the dedicated Jacqueline M. Lentz Comprehensive Breast Center breast imaging team, where he is providing service across the southern region. Committed to delivering exceptional patient care and advancing the field of breast imaging, Dr. Simon is dedicated to improving outcomes through early detection and innovative imaging techniques. So thank you, Dr. Simon, for doing this with us. We appreciate it, and the floor is yours. Thank you so much.
Thank you very much for those kind words, and thank you for having me today. As you said, I'm Dr. Simon. I'm part of the Robert Wood Johnson team, and I am part of specifically the Jacqueline Lentz Breast Center, where we perform dedicated breast imaging. And I look forward to discussing breast cancer screening and its importance today. So we're going to discuss, or my goals are to discuss the different imaging modalities that we can use to screen for breast cancer, including those available for high-risk individuals. And also, I'm going to attempt to dispel myths and misconceptions about breast cancer screening. And we all know that those are a few too many. So what does breast cancer screening mean? Screening is defined as an examination utilized to look for an illness in people who do not have any symptoms. The goal of breast cancer screening is early detection, diagnosing cancer before it manifests itself, like forming a breast lump. And anecdotally, I've often have had patients who come in and say, why do I need a biopsy? Why do I need to do screening? I feel completely fine. There's nothing wrong with me. And unfortunately, cancer doesn't always manifest itself with symptoms, but you could feel completely fine. But the whole point of screening is to catch things early when you still feel fine. Research has shown that cancers detected during screening tests are more likely to be smaller and less likely to have spread outside the breast. When diagnosed at an early stage, 99% of patients will still be alive 5 years after diagnosis. For high-risk individuals, regular screening is crucial to detect cancer early. And we're going to go over what constitutes a high-risk individual a little bit later. So now there are a few different ways that we screen for breast cancer. The gold standard for breast cancer screening is a mammogram, and this is performed for women who are 40 years and older. It's a low-dose X-ray. Recently, over the past few years and decades, a newer type of mammogram called a digital breast tomosynthesis, which is also known as 3D mammography or TOMO, has become more common. What's unique about this feature is that it finds more breast cancers because it allows us to look at the breast millimeter by millimeter and can be helpful in women with more dense breasts. And we'll go over what dense breast means a little bit later as well. All mammograms at the Jacqueline Lentz Breast Center utilize TOMO technology and are analyzed by both a physician and artificial intelligence. And we're actually in the process of upgrading our artificial intelligence at the center. So this is just an image of what a standard mammogram looks like. So during a mammogram, the patient would stand in front of the machine and the technologist will place their breasts between compression plates. The plastic upper plate is then lowered to compress their breast for about 10 to 15 seconds while the technologist takes the x-ray. Between 4 to 6 x-rays are taken for a standard mammogram, and the whole procedure takes about 20 minutes. Compression is important because it lowers radiation dose as less x-rays are needed to penetrate the breast. It also makes the image crisper. Another tool used for screening is the ultrasound. Now, the ultrasound uses sound waves to make pictures of the inside of the breast. It's used as a supplement to a mammogram and is not a replacement. Remember that a mammogram is the gold standard of screening for breast cancer. Ultrasounds are great in younger populations and those with dense breast. Another modality that we use to screen for breast cancer is MRI. MRI uses magnets and radio waves to make detailed photos of breast tissue. It has the ability to detect cancer that's clinically and mammographically occult, meaning that it's not seen on a mammogram and it's not felt or as a lump or is able to be detected without imaging. During the MRI, the patient will lie on a table while their breast is positioned inside a larger MRI machine. The machine will then take images of the breast. Contrast dye will also be given through an IV in the arm, and the procedure typically lasts 20 to 40 minutes, and you may be asked to hold still and avoid moving during the scan to allow for better imaging. Now, breast MRI is utilized, but is mainly used in higher risk women because it has an increased cancer detection risk and is more sensitive than both mammography and ultrasound. Because of that, oftentimes, although it will find cancers at an earlier stage, it will also capture more findings that we'll want to investigate further and potentially biopsy. So that's mainly the reason why it's utilized for only the high-risk populations. Additionally, it does not involve any radiation, which makes it a safer option for those who require more frequent screenings. So now, for an average risk woman is someone who, based off of an algorithm, their risk factor is below 20% lifetime risk of developing breast cancer. And that's based off of when their menstrual cycle started, how many children they had, their breast density, their family history, and any genetic mutations. So for these women, multiple societies, including the American College of Radiology, the Society of Breast Imaging, the U.S. Preventive Services Task Force, and the American Cancer Society recommend starting annual mammograms at age 40. This gives the most benefit in saving lives and reducing mortality from breast cancer. For high-risk women, and these are women with a greater than 20% lifetime risk of developing cancer, which, as mentioned before, could be related to family history, genetic mutations, etc. Screening schedules should be tailored to their specific situation and discussed with their healthcare provider. Typically, these women will start screening MRIs at age 25 and yearly after that, and mammograms at age 30 and yearly after that. Screenings are earlier because we want to make sure that we are extra careful with these high-risk women so that we catch any changes or any chances of developing or any small little findings earlier. Okay, so now I've convinced you to get a mammogram or to get screening. But what's breast density? Now, I'm sure everyone's heard of dense breasts. As you can see, there are multiple news organizations which have reported on breast density and its impact on detecting cancer. So let's explore this a little bit more. So breasts are made up of a mixture of fibrous and glandular tissue as well as fatty tissue. Breasts are considered dense if they have a lot of fibrous and glandular tissue and less fatty tissue. Breast density is not how the breast feels, though. The radiologist who reads the mammogram determines which breasts are dense or not. So you could see on these images, we go from a fatty breast all the way to a dense breast. And my next slide will show why it's important, or this distinction is important. But just the main reason why this slide is, I wanted to bring this up, is because you can see that there's brackets underneath showing what's considered not dense and what's considered dense. And that discrepancy will lead to additional screening recommendations, and I'll go over that in a few minutes. So this is why breast density is important. So in dense breasts, as we mentioned, fibrous and glandular tissue appears white. This area, as you can see, the whiter area on the mammogram. And fatty tissue appears black. So lumps or masses, both benign and cancerous, also appear white and can be hidden by normal dense tissue. Although we've had the advent of 3D mammography or tomosynthesis, and it has helped increase the number of cancers seen, even in dense breasts, additional tools or tests may be needed. And we could see that on the left side of the image, a small cancer is easily seen in a fatty breast, but a larger cancer in a denser breast is more difficult to be seen. Okay. So now your breasts are dense. How are you supposed to even know that? And what does that mean? So in September of 2024, the FDA required that all mammogram reports being sent to patients must include breast density, and it will be described in the report as either not dense or dense. You still need a mammogram if you have dense breast, because although it might be a little less sensitive, it is still considered the gold standard. Supplemental screening with either ultrasound or MRI, though, might be recommended. And at our breast center, we routinely recommend ultrasound in addition to mammography for anyone with dense breasts, which would be in the category of heterogeneously or extremely dense. So now going back to screening, you get called back. Do you need to be afraid? What does that mean? So don't be afraid if someone tells you that you need to come back after a screen mammogram. It's very common and sounds worse than it actually is. 1 in 10 women, or 10%, will be told to come back after a screening mammogram for additional images. There are multiple reasons you could be called back after your screening mammogram, including a technical recall, which is if the images taken are not technically adequate. For example, if there's some motion on the images and we're not able to clearly see what's going on, or there might be a finding that the radiologist wants to take a closer look at. If you get called back, you will likely need to get further imaging, which might include getting more additional mammogram images or potentially an ultrasound. Now, at this appointment, you will be given the results of the test at the end of the visit, with further recommendations in terms of follow-up. There are a few different standard follow-ups that are given to patients at the end of this visit, and they are as follows. You might be told that there's nothing to worry about, and you can return to your normal mammogram schedule. You can be asked to schedule your next imaging test sooner than normal, typically in 6 months, to watch an area closely and see if it changes over time. And least likely is being asked to come back for a breast biopsy in order to know for sure what is going on in the specific area that was questioned. Now, keep in mind, only 1 to 2% of screening patients are asked to return for a biopsy. Additionally, bringing your prior mammograms and ultrasounds are extremely important. Radiologists need to compare your current mammogram to prior mammograms in order to see if anything is new compared to years before. Having prior mammograms decreases the chances of getting called back after a screening. I just want to touch on another very important and less commonly thought of way in which getting your yearly mammogram can actually potentially save your life. Cardiovascular disease is a leading cause of mortality of American women, even more so than breast cancer. If cardiovascular disease is detected prior to symptoms, major adverse events, such as heart attacks, can be prevented through lifestyle modification and medication. Recent studies have shown that breast arterial calcification, which referred to deposition of calcium in the walls of the breast arteries, as you can see on this example, and it's circled in yellow on a mammogram, that when those are present, there's a 2.5-fold increase in cardiovascular disease prevalence. So we're able to report these findings on our mammograms, and our breast center does this. And if these are seen, we actually put in the mammogram report that the patient should be referred to for a cardiac risk screening for additional imaging. Okay, so now let's clear up some common myths. So myth 1, mammograms increase the risk of cancer. Now, I've heard this a lot from patients, especially in the southern region, and it's not unique to the southern region of New Jersey or where we're based, but it's something that has been going around, especially on the internet. So mammograms are low-dose X-rays of the breast. There is radiation, but it's a very small amount of radiation. Now, keep in mind that radiation exposure of any kind can increase your risk of cancer, but the levels are minuscule in a mammogram compared to the 13% chance that an average woman has of being diagnosed with breast cancer. Over 40% of US breast cancer cases are found because of mammograms. So it's extremely important to get regular screening. If you're nervous about the radiation dose that a mammogram gives, feel free to reach out to your physician or to the breast center that you typically go to. And I'm sure that the radiologist or your physician, your primary care physician, will be happy to discuss these concerns with you. But what I often tell patients is that they should keep in mind that a cross-country flight round trip gives you more radiation dose than a mammogram. And no one really thinks about radiation when they get on a plane flying across country. They just go, oh, I'm going to have a good time at, let's say California, since we're based on the East Coast. Let's have a great time. Let's go to the beaches, etc. But when it comes to screening and the importance of their health, everyone all of a sudden becomes very strict on radiation dose, and we can't have it. It's going to give me cancer. So just keep in mind that when you go for your mammogram, it might not be as pleasurable as going to the beach in California, but it's the same exact amount of radiation. So another myth, ultrasound or MRI can be used as an alternative to mammography in order to avoid radiation. So as we had mentioned before, mammography is the gold standard of care when it comes to diagnosing breast cancer. Breast MRI and ultrasound can be useful tools in our arsenal, but they cannot be used as primary screening methods, and I'm going to show an example of why. No major cancer or medical organization recommend any other primary breast cancer screening method besides a mammogram. And although clinical breast exams are wonderful detection methods, they are not replacements for mammograms. So now you could see on this image of an example of a mammogram, and you could see this linear white line or very white line, and that's calcifications. And you can see branching off of those off of that main white line, additional calcifications. And this is an example of what suspicious calcifications look like. In this specific case, these are calcifications lining milk ducts of the breast. This would be extremely difficult to be seen on an ultrasound and even on an MRI. This was ultimately biopsied and came back as DCIS, which is stage 0 breast cancer. Now, another common myth is that mammograms are not safe in pregnancy and lactation. So the dose of radiation that would reach a fetus during a mammogram is much lower than the threshold for any effect from the radiation. It is of absolutely no clinical concern. Early on in pregnancy, the uterus is still within the pelvis. And remember, we're imaging the breast, which is in the upper chest. So the radiation is not going anywhere near there, and the scatter radiation is minuscule. Fetal mammographic doses are orders of magnitude below the estimated threshold for any radiation effects. Additionally, there is no contraindication to mammography during lactation. There's no need to pump and dump after receiving a mammogram, or for a breast MRI for that matter. I will say, though, that although mammograms are safe in pregnancy and lactation, and ultrasounds are as well, MRIs during pregnancy are contraindicated because of the contrast. So if you are high risk or you are pregnant, you should factor that in regards to your breast MRI, and you should discuss with your breast center or with your primary care physician. So this is just an example of artificial intelligence. So of how it comes into play and how it helps us detect cancers. So this is one view of a mammogram, of a screen mammogram, and you could see on the top of the image there's this little white area, and a zoomed in image of that area shows that it's a little ill-defined. The borders aren't so crisp, and there are some speculations coming out of it. So this was deemed suspicious by the radiologist. It was run through artificial intelligence, and this is what the artificial intelligence that we're upgrading to is going to look like. And you could see that the artificial intelligence highlights the same area in the right breast, and it called it elevated suspicion. And this then led to calling the patient back. We did additional mammographic images, and then we went on to ultrasound, which is typically our course when we call patients back for a diagnostic finding. And on the ultrasound, we could see the white area is normal tissue. The darker area is also normal tissue, but you could see this really black area surrounded by the white area. And that area was deemed suspicious and felt to correlate with the finding seen on mammogram. It was ultimately biopsied, and this is what an invasive cancer looks like. Now, the next image that I'm going to show is what we're trying to avoid. It's not meant to scare anyone, but I just want to show what happens when patients wait. They don't come in for their yearly mammograms. They feel lumps. They say it's absolutely nothing. But again, it's not meant to scare anyone. But this is an example of an 80-year-old who felt a lump, but she didn't come in for a number of years, clearly. And this mass was protruding from the skin. It was bleeding. She came in for a mammogram now. One of the images is shown on the slide, and this was ultimately biopsied and came back as a cancer. And this just highlights the importance of screening mammograms, screening ultrasounds, screening MRIs, feeling for areas. If you feel an area, come into the breast cancer center, the breast center for further evaluation. Most of the time it's going to be nothing, but we'd rather you come in, we screen you, we make sure that it's nothing, as opposed to feeling, oh no, it's nothing, and then it morphs into something like this. So just some key points and just review. Regular screening is critical to finding breast cancer early when it is most treatable. We have powerful imaging tools to give us detailed, high-quality images of the breast, such as breast MRI. Remember that the gold standard is still mammograms, and oftentimes mammograms and ultrasounds are the only tests that a patient will need in their lifetime. But the MRIs are especially advantageous for high-risk individuals. Consult with your healthcare provider or come see us at Monmouth Medical Center or the Jacqueline Lentz Breast Center to discuss your screenings and when to start screenings. Thank you very much. I'm here to answer any questions that you might have, and we're here to help.
Thank you, Dr. Simon. This was wonderful and informative, and the pictures and the imaging was so easy to understand and follow. So thank you for all of that and for your insight. I do want to open it up for questions. So if there are any participants here who have questions or have a comment for Dr. Simon, the floor is yours. I have a few myself, but I'll let the audience go first.
I actually have a question. So for the calcifications in the breast arteries, so that is reported in the report. Does that also go on the patient version of the report? Like if they're on my chart, like will the patient be able to see that information on that report in their my chart account?
I believe so. It should, I typically mention it in the body of the report as well
Okay,
as in the impression. So it should, and then in the impression, there will be something that's saying consider further evaluation with cardiac screening or refer to your primary care physician. That whole field of breast arterial calcifications is really a brand new field. That's a lot of new literature is being written up on it, but it's something that, we're really trying to start reporting on and to make patients aware.
perfect. Thank you.
I just have a question. And what makes us different as a comprehensive breast center than as if somebody went to a regular off-site center just doing screening mammograms, diagnostic mammograms?
Okay, I'm going to try to be very politically correct here. So at a comprehensive breast center, you have breast imaging radiologists who have undergone specialized training in breast imaging. A lot of those findings, like those calcifications that I showed within the milk ducts, those are oftentimes subtle findings. And when you go to other locations that are not comprehensive breast centers, you oftentimes don't have radiologists who have undergone this specialized training. They've just been self-taught, which is totally fine, but they're not as experienced. Additionally, when you come to a comprehensive breast center, you have everything on site, meaning you have mammograms, you have ultrasounds, you have diagnostic mammograms, you have breast MRI, you have the breast surgeons, you have the social workers and the coordinators. Everyone's here, so you don't have to go to an outside location, get a screening mammogram, get told that you need to go for additional imaging, go pick up those images from somewhere, go to a different site. Then after you go to that site, bring all those images to a different breast surgeon. We make everything simpler, and that's our goal. Our goal is not to scare anyone. Our goal is not to try to frame people away. It's to make everything as easy as possible, as seamless as possible, and to make everyone as comfortable as possible. I hope that answered that question.
Thank you.
We have a comment in the chat that Karen says, thank you, excellent information. Every center should provide this level of support to people. And I agree. It's always wonderful to have the one-stop shop, for lack of better words, to make sure people feel like they're being handheld through the process, which could be very scary for some folks.
Definitely true.
I want to open it up for questions. If people have trouble taking themselves off mute to ask their question, you can certainly put it into the chat box.
Bags on the floor. I'll come in.
I do have a question. So we'll actually have a comment and a question. So the first one is the comment. So you talked about the calm, then the calm and the callback, right? If you're getting called back for a second mammo or an ultrasound, don't always panic. And I think that's a message that we need to continue push in the community. Oftentimes that creates so much fear that people will not go back, right? So thank you for putting some emphasis on that piece. The question that I have though for you, Dr. Simon and our team, is what about for people who have limited health insurance or no health insurance? Can they still participate in your programs? And if so, how can we have that be the case?
Yeah, so definitely they could participate. I believe, and I'm not as familiar with the nuances of the program, but we do have a program called SEED, which does help those of lower income, those who don't have insurance, et cetera, to come get a screening mammogram. And we also have charity care, which helps pay for patients getting biopsies or more advanced care. We don't try to, anyone who wants to come in, we always try to help them and make our care as accessible as possible, because someone who comes in with a concern, it's not in our interest to, oh no, you can't pay for it, go away. Like, that's not how we operate at Robert Wood Johnson. And we really do try to capture as many patients as possible, and we try to help them as well. And just in regards to the callback and the calmness of it. It's not only unique to breast cancer screening. Like whenever someone goes for a blood test for anything, they assume the worst. If they come in for a biopsy, they assume the worst. And it's a natural thing. It's our job as the physicians, as the breast center, to try and calm them down and allay their fears. Obviously, there are some cases which are more concerning than others, and we try to slowly break the news to those patients so that there's no shock when we actually tell them what the diagnosis is. But it's funny because up until a few years ago, the USPTF, which is the US Preventive Task Force, had said that women should come every 2 years for their screening mammograms, not every year. And that was because of the anxiety that going for a screening mammogram caused. That changed because they found that they missed so many cancers were being missed at an earlier stage that they changed it only recently, I think 2 years ago, to every year. And that just highlights the importance of screening. Yes, it could be scary. Yes, it is nerve-wracking. We try to read all our mammograms, our screening mammograms the same day. Sometimes we might be a little bit behind, but any patient who comes in is more than welcome to ask for an earlier read. I can't promise that we'll be able to accommodate everyone if everyone comes in for that, but usually our turnaround time is less than 24 hours. So we try to get that out as quickly as possible in order to make patients as calm as possible.
Wonderful. Thank you for that. And yes, we at the VNA Children and Family Health Institute do work with the SEED Cancer Education and Early Detection Program. Oftentimes we'll be out at community events together, and Mika and Lady will be with us, and we'll try to coordinate those appointments and to help the families who may have limited or no insurance. So it's been a wonderful partnership, and we love that. So Karen has a question in the chat, and the question is, at what age should people begin this testing?
Okay, so for average risk women, and if you're average, you could assume you're average risk if no one in your family's had breast cancer, everyone's been healthy. So those screenings would start at age 40. Now, when you go for your first screening, you're going to be asked to fill out a questionnaire, and that questionnaire will give us an actual percentage of what your risk score is. And it's called a Taracusic score, but that's an algorithm that's used throughout the country by all the leading comprehensive breast cancer centers. So if that score is 20% or below, then you're still considered average risk, and you'll go for your yearly screening mammogram. If you have denser breasts, then we will recommend that you get supplemental screening in conjunction with the mammogram of yearly bilateral risk screening ultrasound. If you have a family history of breast cancer, or you have a known gene mutation, such as the BRCA1 or 2 mutations, there are additional other genetic mutations that might be present. Or if you've had a history of lymphoma with chest radiation as a child, you might be recommended, you probably are high risk, and you're going to be recommended to start screening earlier. We try to capture these patients with breast MRIs starting at age 25, and then yearly screening mammograms starting at age 30. Oftentimes what we try to do is alternate the screening, so you don't come at the same time for both the mammogram and a breast MRI, but you'll come for your breast MRI, then 6 months later you'll get your screening mammogram. 6 months after your screening mammogram, you'll come back for your breast MRI, and so on and so forth. And that just allows us to get good screening tools every 6 months, and it's not necessarily more frequent screening, but allows us to capture and make sure that our eyes are on you to catch any small changes that we might see.
Thank you, Dr. Simon. And in the meantime, in between annual or more frequent appointments, depending on the person's risk factors, like you mentioned, can you talk a little bit about self-breast exams that folks can be doing, regularly on their own as a self-health advocacy piece?
So before average risk group women, really starting like at 20 or in their teens, they should be checking their breast every month. So one of the first things, someone had come up with a line of feel it on the first. So on the first of every month, you just do a self-breast exam. The easiest place to probably do is in the shower, and you just start feeling your breasts. Now, you're going to feel weird things. It's just normal. Also, depending on the time of the month, depending on different hormonal changes, things might get larger, smaller, and it's fine to come in. Anyone who's under 30, you'll come in, we'll just do an ultrasound of that area. But again, it's better to be on the safe side for these examinations. So feeling it, just touch the area, feel all four quadrants. And as you do that more frequently, you'll be able to feel what's normal, what's not normal, what's changed, what's not changed. And if it's really in between all the screening that you might be doing, feeling it on the first is a great way to just making sure that everything is, kept in check, and nothing has changed dramatically, or subtly. Additionally, this is something that I didn't really bring up in the slide point, but there's also, even if you're pregnant, you should still be doing these examinations, and not necessarily the mammograms because that's once a year, but for younger individuals under 40, you should still be feeling the breast, and there will be a lot of changes during pregnancy, especially if one is going to be nursing after pregnancy also. But there's something called pregnancy-associated breast cancer, and that is defined as breast cancer that's associated with someone who is pregnant or up to 1 year after pregnancy. And although it's a pretty rare finding, at the breast center at all our sites, we've actually had in the past year, if I counted correctly, about 8 patients, and they were as young as 25. And they felt it by feeling it. And this is not trying to scare anyone away from, oh my gosh, something bad's happening, but it's something to keep in mind. Anyone is at risk for cancer, and that making sure to do those self-breast exams is important. There will be a lot of false positives, which are just findings that end up being nothing, but come to the center, we'll do an ultrasound, we'll allay any fears, and yeah.
Thank you. Very important. Out in the community, we have a model that we put out on our table. As people come over, we encourage them and try to teach them how to do a self-breast exam, because sometimes people don't realize they should do them, and when they realize they should, they don't realize how to. So thanks for clarifying that. Does anybody else have a question? I have one last question, but I'd like others to go first if they have questions. Okay. All right. So the last question that I have, Dr. Simon, is about nipple discharge. Sometimes women will come to us and they will say that they experience nipple discharge during a mammogram. Is that typical? And also, how can we, if it is typical, how can we help families understand that, yes, nipple discharge can be a sign that you need to get looked at further because it can indicate something unusual, but also during a mammogram, that may be something that is typical. Can you talk a little bit about that piece?
Sure. So there's there's 2 types of nipple discharge. There's spontaneous and non-spontaneous. So compression during a mammogram would be considered non-spontaneous, meaning we're doing something to the breast, or the patient's doing something to the breast to express that discharge. Those are typically less concerning. It depends also on what the discharge looks like. If it's clear, less concerning. If it's milky, less concerning. Things that might be a little bit more concerning are if it's bloody or if it's yellowish, because yellowish could be just a degradation of blood products. If it's spontaneous, meaning it just occurs naturally, again, the same parameters do apply, meaning if it's milky or clear, less concerning. But if it's bloody or yellow, a little bit more concerning. I'm not trying to scare anyone by saying more concerning, oh my gosh, but it's definitely something to look at. It happens to be that when you're getting the mammogram, if our technologists are excellent, and usually they'll write a patient noted discharge on some of our sheets. So we'll pick up on that and then we will comment on it if we feel it's important, if we see something. But those patients, any patient who has a nipple discharge, unless it's clearly milk, they should probably come in just to make sure that everything's okay. It's sort of hard to give a catch-all, but findings that are concerning that could cause these discharge, obviously cancer is one of them, but there are other pathological diagnoses such as an intraductal papilloma, which is a benign finding, but it is considered high risk. Sometimes that pathological diagnosis could be hiding some atypical cells in it. So typically if we see nipple discharge, we'll have the patient, or if there's complaints about that, we'll have the patient come in for a mammogram and an ultrasound. If we see something, we'll typically be more aggressive and biopsy it. And then if it comes back as that papilloma, we'll refer them to a breast surgeon. I hope that clarified. I hope it wasn't more concerning or more confusing.
No, that was great. It's exactly what I was hopeful for, because there is a difference and it can mean different things. So again, don't press the panic button, but perhaps get it checked out.
Yes.
Thank you. Okay, final call for any questions or comments. You can take yourself off mute or you can put it into the chat box for Dr. Simon. Okay, I'm going to do one last check of the chat. Okay, I don't see anything. So I will thank the RWJ team and especially to you, Dr. Simon. Thank you for doing this with us. We really appreciate your time. And to all the participants today who came out and spent your morning with us, we appreciate your time as well. Just a couple of quick updates on some of the things that we have going on. At the beginning of this meeting, I mentioned that Ocean Monmouth Health Alliance, as well as the whole VNA organization, has transitioned to Microsoft Teams. So we are using Teams today for the first time together, and moving forward, we can anticipate to continue to use. No more Zoom links from us. So I apologize for the many reminder emails, but I just want to make sure that we're getting the message out to everybody who needs to know. That's number one. The second thing is that this particular Our Health to Hold series will happen again for the final session in November. And that will be on November 19th. Again, it's a Wednesday from 10 to 11 a.m. It will be virtual via Teams, and we will have Vital Breathwork. We'll have Sydney Pentland from Vital Breathwork with us, and she's going to be talking to us about lung cancer awareness because it is Lung Cancer Awareness Month in November. The other thing to highlight in November that we have is an Ask, Advise, and Refer training, and we are collaborating with the cooperative to promote that in the community, and that's going to be on Wednesday, November 12th from 12 to 1 p.m. It's going to be kind of like a lunch and learn. Maya, I believe, is here. So Maya, thanks, and shout out to you for doing that with us. We're excited for it. And finally, the other thing that we have to note is a virtual quarterly coalition meeting, and that's where all of our coalition members come together and everybody shares program updates. We talk a little bit about some of the collaborations we've had in the quarter, and we just invite everybody to meet and greet and share. So that is on November 5th from 10:30 to usually 11:30, but we say till 12, 10:30 to 12, and again, it's virtual. So if you are able to join us for any or all of those things, we encourage you to please do so. And certainly you'll be getting more information from me via email about all of those opportunities as well. So thank you, everybody. And again, have a wonderful day. Thanks for being with us this morning. Take good care, everybody.
Thank you.
Thank
Have a
you.
good day.